So you were asked to talk about the barriers that commissioners face in identifying poor quality care and what needs to be done about it. So tell us a bit about what came out.
Do you want me to stand up? Yeah. We had a very interesting debate on the table. We concluded a number of things. I'll try and be brief. Firstly, a greater proportion of the standard contract value should be based upon quality payments. But quality payments that have some local determination and actually build over an extended period of time, that aren't just a one-year initiative. We then went off at a different tangent, and we talked about the quality and the capability of managers who will find themselves within CCGs. We need jobs working in CCGs to be attractive jobs, and to attract the right people. We need people who have got skills that are able to transcend the system. The table thought it was a really good thing that one of the premiums you get for GP-led commissioning is the fact that most GPs will have done some of their training in hospital and they understand the hospital system, giving rise to a better quality of conversation that will take place between commissioners and providers. But we also concluded very clearly that we need doctors first and foremost to be doctors and leaders of the system. We do not want our doctors to try and become managers and kind of just replicate what the PCT used to do. We also acknowledged that there was an issue that we have a danger of recreating the past, that if we have too many small CCGs to start with, we dilute the quality and the availability of management resource that is available to them. And again, if we go back to Judith's work this morning, over time, our commissioning approach has tended to migrate towards larger populations. And what we have to be very careful about is that we don't start off clinical commissioning groups without the capability and capacity to do some of these challenges. The next point, very simply, huge desire and need to create as much stability at commissioner level as we possibly can. Going back to the very first point, we then talked about a greater opportunity for patients to be involved in the whole process, right through the cycle, but we actually concentrated that discussion very much on patients being involved in setting the quality metrics, helping us to say what's right to measure in terms of quality, but then being involved in kind of the monitoring and the outcomes that flow from that. I'm sorry this is about out of order. Returning to the capacity and the capability issue, making sure that the clinical commissioning groups really have the capacity and capability to learn the lessons from past failures, to actually look and address those in a systematic way.
So looking forward to Robert's report, that they will take some of those recommendations and have the number of people, the right information to kind of make sure providers do it.
But yes, but to actually be able to see that providers are running that in a systematic way, not to step in and do it for them, but to be able to see that they're doing that. And then finally, one last point from us. We had a debate, and I'm not quite sure what's the right way to phrase this for you, but the culture of the clinical profession representing a barrier to the embedding of kind of systematic quality review processes. And we talked about kind of the culture of medical training and therefore how receptive some of our clinicians within hospitals are going to be to the kind of challenges that are necessary if quality is going to be at the forefront of everything we do.
Absolutely, and we heard some of those issues in the seminar on quality, and I think indeed Steve mentioned it earlier on about the training that doctors get in improvement science, that some feel that medicine is still an art and we should be allowed to practice our art in whatever way we want to do it. So you raised quite a lot of solutions rather than barriers, so that's good, but does anyone want to come in on that or make some other suggestions?
I think it's a very sweeping statement saying that medicine is an art and we ought to be...
I was caricature.
Even so, I think we just have to be fairly precise that it isn't. It is a very exact science. It does have art areas in it, but it is a scientific discipline.
The point that the group were making about the capacity of clinical commissioning groups to be able to do the job, pointing to larger aggregations rather than smaller ones. Does anyone want to come in on that one?
It's just that I remember when Judith presented a seminar on integration recently, and Chris and Judith, everybody says you need to have bigger commissioners like internationally. And we've had big organisations like SHAs, and nothing has come from them. Yeah. And in one sense, we almost need a disruptive technology to reshape the future, and maybe that's where CCGs are. Yes. And because the big people haven't delivered on a big-scale approach. They haven't combined PCTs, apart from odd places like Manchester. You know what I mean? We've failed in the past.
Do you think perhaps we're talking about different things? You need the analytical muscle, but you also need the personal relationships of the clinicians to clinicians in their local settings.
I think it's a paradox, but I think the way we were trying to make the point is if you have too many of these organisations that try and be self-sufficient, yes, we dilute the quality of management capability. Yes. And I just go back and say again, first and foremost, we want our doctors to be doctors, then we want them to be system leaders. We don't want our doctors to become managers. That's a kind of waste of their training and a waste of our resource.
There was also something that the group mentioned earlier on, a larger proportion of the national contract linked to quality payments that are negotiated and agreed locally. Is that something that others would support? Is that a good idea?
Yeah, it's something we tried in Bradford in ECT some years ago and actually improved the quality of care because we had local flexibility. The reason we had local flexibility is we had funding in the system to allow us to do that.
Just a question on that. Did you, were these one-off things? So when the quality improved, you then moved those incentives onto other things?
That's right, yeah. Okay. So we put on a 12-month stop and then moved on to the next thing we wanted to do.
The rolling programme. Yes.
I do think we have to recognise the financial situation that we're working in here, though, with this, because when we have done this in the past, we've actually had quite a lot of money in the system. To have that in addition, this would mean that we were taking money away from people if they were not delivering, and that could have very significant consequences. Yeah. So we need to think about the failure regime in the providers alongside this.
Yes, it does suggest that it might be an even more poignant or added weight to the incentive, though, doesn't it?
Well, sorry, can I just come back on that point? We had a director of a very large acute teaching hospital at our table, and again, I think it was her who instigated the debates that talked about a greater proportion of the current payment being linked to quality.
Yeah.
So there was an absolute acknowledgement that this isn't more money or new money, it's a greater proportion of the existing money, and actually it was our colleague from an acute trust that kind of forced that debate on our table.
I just wanted to say that the new tribalism is about teams, and clinicians are more than doctors. It's about clinical teams working together to move forward. And the evidence from Aston University about who make the best managers are actually clinicians who really want to understand the total amount of care.
It's just worth commenting on that theme that GPs run small businesses. They are already managers. It's about making sure we make the most of their skills and use them appropriately, not have them as a badge of you are a clinician, go and be a clinician, because they're already managing.
Yeah, so, yeah, okay, so it was a bit of a soundbite to say don't make them into managers, but they are in commissioning for their clinical skills.
And their management skills.
Okay.
There's lots of
management skills. Okay.
Yes.
So don't reduce it to one or the other. They've got both.
They've got both. And the other thing is that it's your commissioning support you need to structure so that you have capacity where you need it, perhaps over a wider area. But your CCGs need to be very, very focused on your local communities.
Just on the capacity issues, we heard from the case study that they'd got a particular problem with one service and had moved capacity into that. How important is it for clinical commissioning groups to have flexibility in that capacity and where they direct it to?
Well, it's vital.
Mark.
I think the point that you made around the opportunities of the current financial environment is really poignant there. So we cannot afford to carry on doing the way we have done things in the past, and we'll be faced with some challenging prioritisation decisions, and that in itself is an opportunity, and it's an opportunity of looking at things in different and creative ways. Just coming back to the kind of the clinicians as managers point, as a clinician who's been a manager for a long time, I think it's really important we don't confuse using the clinical output the clinical background as a really important input into strategic planning and strategic leadership, and we confuse that with management. So I'd see the real kind of particular value of clinicals is around strategic direction and around leadership rather than management per se.